Uh, I'm Lee Fleischer. I'm the CMS Chief Medical Officer and Director of the Center for Clinical Standards and Quality. And I'm really, it's a privilege today to be here with two colleagues, two other center directors from CMS. As you may be aware, CMS has 6 centers in addition to a lot of offices. The centers report to the administrator. And we thought we'd start out today by really explaining what we do in our centers and then talk about how that ended up leading to the alignment paper in the Universal Foundation and how we're thinking about that within the equity framework. So I don't know if Liz, do you want to?
I think we should start with
Mina, yes.
So hi, Mina Seishamani. I am the director for the Center for Medicare. The Center for Medicare basically is the hub for policy and operations for the Medicare program, which, as you may know, covers more than 64 million people. We pay almost $1 trillion in claims each year. We partner with more than 1 million clinicians, 6,000 hospitals, skilled nursing facilities, home health, et cetera, et cetera. And it really is an incredible opportunity for us to really drive change, not just for the millions of people in the Medicare program, but for the health system writ large, where changes happen in Medicare, a lot of times that influences other parts of the healthcare system. And at a high level in the Center for Medicare, we really are trying to drive several aims that are common across CMS. So, as we're here today to talk about advancing health equity, this is something that we think about in our programs, both through specific policies that we can put in place to really address issues of disparities, to look at health-related social needs, to make sure that everyone has a fair and just opportunity to attain their optimal health. But also, we think about it in our everyday operations of the Medicare program, because if a program is not easy to navigate, it is not the MD, PhD who has trouble, right? It's people who have complex medical and social needs, people who maybe have limited English proficiency, don't have family resources. And that is something that we really take to heart with everything we do, with navigating the system, with our payments, et cetera. Being able to really expand access to coverage and care, driving innovation for high quality, whole person care in partnership with, my colleagues here. And, being able to be good stewards of the Medicare program, making sure that all parts of the Medicare program, from the traditional Medicare program to Medicare Advantage to the prescription drug program, that everything is moving in that direction towards really changing care for the better, and that the Medicare dollar is being used in the most effective way to do so. So I'm sure we'll get into, some more specifics, but that's kind of, an overview, and I'll turn it over to my partner in crime, Liz.
So I'm Liz Fowler, and I lead the CMS Innovation Center. And you can see why I had her go first, because she's like the 800-pound gorilla that runs the Medicare program. And what the Innovation Center does, we have many of the same goals, and we're partners in a lot of what we do, but we test models, new payment models, new delivery system models, to try to find ways of improving Medicare. And we're at our best when we're working with Mina and with Lee and with Dan Tsai, who leads the Medicaid program, when what we do and what we're testing can inform policy. 2 years ago, we announced a new strategy. So for those of you who don't know the Innovation Center, we were part of the Affordable Care Act. So we're a very new part of the agency. We started in 2010, or after the law passed. We have $10 billion that renews every 10 years to invest in these new models. So in 2021, when I came in, we took a look at the models that we've been running over the last 10 years, 50 plus models, and tried to take those lessons and chart a new path forward. And we laid out a new strategy. And that strategy focuses on 5 objectives. First is driving accountable care. We want everyone in the healthcare system, and this is something we're working closely with Mina on, to have a relationship with a provider who's going to help them navigate the healthcare system, whether you're in Medicare or Medicaid. And that's we don't have, our statute doesn't float over the marketplace. So we're just Medicare and Medicaid, but we want everyone in Medicare and Medicaid to have access to a physician who's looking out for their care. and their quality of care. The second is we said health equity is a primary pillar that we're working towards. And if you heard from Dr. Dora Hughes, who's our Chief Medical Officer, we're embedding health equity into everything we do. When I came on board and asked about the models that we'd run, like, okay, have we made a difference in reducing disparities? The answer was we didn't know because we either weren't collecting data or it wasn't a focus, or when we did our evaluations, it just wasn't top of mind. And so we really committed to making sure that everything we do has equity in its mind. So we collect data on race and ethnicity and social determinants of health. We are committed to embedding social determinants of health as well as thinking about the evaluations. We're trying to build out our strategy to incorporate more safety net providers. Turns out the organizations participating in our model were the really well-resourced ones. They weren't in areas where people of color live. And so we've really committed to making sure that we're recruiting providers that serve all of our patients in our communities. Today, for example, we just announced a new model in primary care, and it has a specific track that's dedicated to federally qualified health centers, so FQHCs, with resources to help them participate and be successful in the program. The third pillar is thinking about supporting innovation. So, and this is related to bringing in the safety net organizations, making sure that all of the model participants have the tools and the resources, the data, and the anything they need to be successful in the models. And that means whether you're a well-resourced health facility or one that's, maybe struggling a little bit, making sure that we're giving them everything they can to be successful. Affordability is our fourth pillar, and that's affordability for patients as well as, of course, Medicare. The statute is really clear that we're supposed to be saving trust fund dollars, but I mean, if you look around, affordability is such a big issue for patients every day. It doesn't matter what kind of insurance you have. And so we've really started paying attention to affordability for patients. And then the final is multi-payer alignment and really thinking about working with other payers in the system. If we want to move towards value, we have to make sure that we're working closely with Medicaid, with commercial payers, with others in the market, so that any change and transformation in any direction we're heading is going to have a meaningful impact. So that's kind of what we're doing. We've announced this strategy. We're starting to roll out new models, working very closely with colleagues, and really excited to be here to talk more about that and also how we work together and try to inform care improvement.
And the Center for Clinical Standard and Quality, as the name implies, it's the non-payment side of the house. It's really about ensuring quality, both starting with the conditions of participation, which are those basic standards by which everyone would practice. I'm going to come back to that. Quality survey and oversight, as well as survey operations, so that we're the group that either sends out the state survey agencies to look at the facilities that that many of our beneficiaries go to. Those include the nursing homes, the hospitals, all 18 types that get funding from Medicare and Medicaid. And as we think about more and more around the issue of should this facility operate in this location because it's below a minimum standard, we ask ourselves all the time now, from the standpoint of the community, is it more important for that facility to keep functioning at a lower standard and we can get them to improve? Or is the community, as our administrator always asks, better served by actually closing that facility? So these are really difficult questions but are critical as we evaluate how to ensure everyone receives that minimum standard, not the incredibly high standards that Liz is trying with really that best high, how did you frame it? High quality, equitable, person-centered care. That's the CMMI True North, but really the CMS True North. We also do coverage decisions that you may see. We do the quality improvement organizations, and we actually oversee the quality measurement infrastructure, except for the CAP study that is used in Medicare. And one of the things that when we came in, and we're talking about a lot, and we can come back to issues of how we think those facilities should actually be person-centered and provide culturally and languagely appropriate services. And that might be something that we talk about at the end, because that's so important to equity, about whether or not individuals really receive care from providers and from facilities that understand their needs and that issue of trust. But in the quality measurement space, soon after the current administration came in, I'm a career official, so I've spanned two, that the three of us started talking about the burden of the measurement system, the lack of directionality of the measurement system, depending on whether it's Medicare, Medicaid, so even within our own marketplace or CMMI measures, are they aligned? Are we telling providers what is important, or are there really 5 measures around diabetes? Wouldn't it be better if there was one clear measure or one innovative measure? We were asked to create a national quality strategy that is actually led by all the center directors, as well as LaShawn McGeever is part of our oversight group. We came up with 8 general themes, which we narrowed down to essentially 4 combined themes. And equity and person-centered care being one of the key initial themes. The other themes that I think are critically important in this area is aligning across the entire care journey, and the idea really from birth to death. There's a lot of focus on the end of life and hospice care, but also maternal health, incredibly important, both from a general issue, but also an equity issue, since we say without equity, there is no quality, as well as trying to get to that or digital system of the future to make it easier. So as we pushed out the national quality strategy, we began to ask the question of that alignment. And we were pushed by our principal deputy, John Blum, to really ask, what would that look like? And that really led to Doug Jacobs and the entire team that has been discussed to come up with that paper of what is a universal foundation that we think all patients should receive. So maybe I'd hand it off first to Mina of how in Medicare we sort of thought about this, and then how the Innovation Center is really that incubator to push us further.
Yeah, absolutely. So before so I am a physician and I'm a health economist. And before I took this role leading Medicare, I was leading care transformation at MedStar Health, big health system in this area. And, you know, between all the disease pathways, disease management pathways that were under my purview, community health, case management, primary care, geriatrics, palliative care, the number of quality metrics that we were trying to track, we had a big spreadsheet, you know, with 8-point font of all the different metrics for all the different programs. So this is something that really resonates for me. When you want to really drive change on the ground, change is hard, even at its best, right? And to be able to harness momentum to drive change in an aligned way is very, very important, because then healthcare providers can understand, okay, where do we want to go? Patients can know how can they be better cared for so that they can be part of that journey and inform it. And so being able to align our measures, I think, is critical to achieve all of the things we've been talking about. Within the Medicare program, there are different parts to the Medicare program. We have our traditional, you know, fee-for-service side of the house. Within that, we have the Medicare Shared Savings Program, which is the largest accountable care program in the country. That has a set of measures. We have Medicare Advantage, you know, where we partner with private health plans to provide Medicare to people. That has its own set of measures. So even within the Medicare program, it sent a huge signal when we were doing our recent round of regulations in Medicare Advantage, and we asked for comment. How do we start to align what's happening in Medicare Advantage with the rest of the Medicare program and with where people want to innovate? And it's received a lot of very positive, I think, energy to move in this direction. And I think speaking to quality, to equity quickly, where you can align a bit more and streamline, it enables you to then take that next step so that we can stratify measures by different patient characteristics. So it's not just about, let me perform better on the average, which could be that those above average get even better and other people are left behind, right? So it presents a really good opportunity to become more granular with these measures so that we can really see across different types of people how are things being done, so that you can really drive equity in everything about quality, number one. Number two, where you can streamline and decrease confusion, it enables you to crystallize better where the gaps are for the next round that you want to look at. And this is where I think doing a lot more around specific equity measures is also very important. And so, having this alignment, I think, is really critical for a lot of what we're talking about, with what we want to do around equity. And I think with the testing, I will turn to Liz.
Thank you. And I'd say the Innovation Center is proudly supporting the Universal Foundation measure set. So we have agreed we need to be aligned as well, but it's still the Innovation Center. And so we still want to reserve like a little bit of flexibility to be able to sort of test and look and press that envelope. So for example, in the model we just announced today, we are using the Universal Core Measure Set, but not all of the measures. And we've also committed to making sure we're incorporating patient-reported outcomes in all of our models. It's really a commitment to try to incorporate, if we really want to be truly patient-centered. So in all of our models, we've also committed to including a patient-reported outcome measure. And that might not be part of the measure set today, but maybe it will be tomorrow, depending on what happens. But the measure set is really important for us as well, because when we test models, we want to make sure that there's also, so we have an intervention group and then we have a control group. And to the extent that the control group is also reporting on the same measures, the easier it is to tell if we're making a difference. And so I think for a lot of good reasons, we're really supportive of the Universal Foundation, the core measure set.
So I want to come back to a comment that you briefly touched on, and we're all have a background in health services and in research. And there was a lot of debate over the last number of years of how to think about how we show the difference between patients in different socioeconomic classes, et cetera, and dual. And what we've been doing more and more, and we just presented back to at least to the hospital side, is really moving more towards stratification. That showing by, in this case, dual status, the readmission measures, and we haven't incorporated that into payment right now, but at least in report cards, we thought was the best way to really highlight those differences. So I'd be curious if the others want to comment.
Yeah, and I will add to what you said, Lee. I think, as many of you know, there has been this debate in how you incorporate differences in populations in quality measurement, right? The whole concept of risk adjustment. And, I think there is a lot of concern that you don't want to risk adjust away the disparities that exist. You actually want to encourage addressing those disparities. So if you just risk adjust, say, hospitals based on the socioeconomic characteristics of their populations, you could actually lead to differences in quality among those populations that is then okay, right? And so instead, we're adopting an approach, to Lee's point, of transparency. Let people really see what is going on, and where can we reward excellent care for underserved populations. And in the theme of alignment across our work, in the Medicare program, in the Medicare Shared Savings Program, so again, where groups of providers, to what Liz was saying, come together to be an accountable care organization, they have quality metrics that they're held accountable to. If they have a high proportion of underserved that they are serving, and they hit these quality thresholds, they get an additional financial reward. So you're in fact investing in those providers that are doing well by their communities so that they can do even more for their communities. Similarly, in Medicare Advantage, we are rolling out a health equity index. So if health plans do well on star ratings for their, dually eligible, disabled, low income populations, that creates a plus up that gets incorporated into a potential quality bonus payment for them. So really thinking about how can we reward care for underserved populations as a way to help, drive the needle on addressing disparities. And again, in that theme of alignment, we have proposed similar type approaches in the inpatient prospective payment system and in the skilled nursing facility prospective payment system, alongside being able to say in our payment rules, like for the inpatient payment regulation, let's look at how these payments shake out with various characteristics of hospitals. We had these traditional ways of looking at it between geography, size, rural, urban. Now we're thinking about, well, how about by hospitals by proportions of dually eligible Medicare, Medicaid that they care for, or by the, socioeconomic makeup of their population, just again, in the spirit of transparency and data, to be able to give that information as well so that it can further the dialogue. And I mean, I think as you all know, the pandemic really enabled us to talk about this a lot more. Disparities and health equity became more household terms as opposed to just, the world of wonks. And I think that's something that we can leverage moving forward to really drive changes to things that have been problems in our country and our health system for generations.
Yeah, I want to echo a lot of what Mina said, because the pandemic, of course, exposed all these disparities that many of us knew were part of the healthcare system for a long time. But then the Biden administration has made it a big priority for everything we do. And that is their instructive from the president on down to try to address these disparities. And so coming into this role, it's part of our strategy, as I explained. We were asked to look at risk adjustment and adjust based on social factors and factors that may lead to underservedness. What we found, though, when we tried to include those factors in risk adjustment, if you think about it, risk adjustment is about predicting future spending. And what happens is if you have under-resourced communities and then you try to predict under-resourced, you use those factors, you end up going in the wrong direction. And so risk adjustment ended up leading to lower payments. And so we instead did what Mina is talking about. We looked at adjusting the payments instead of the risk adjustment. And so in our models, in one of the models we just started this year, if you are serving a higher proportion of historically disadvantaged and underserved populations, you get a payment bump of $30 per member per month. Is it enough? Many say it's not enough. Of course, it doesn't make up for that historical underfunding, but at least it's a start and we can see whether that's making a difference. If you're not serving underserved populations, you actually get a payment cut of $6 per member per month. It's budget neutral, as it turns out. So we're testing this new measure. We define underservedness based on dual eligibility status and area deprivation index. Are those the right measures to measure historical underfunding? It might not be, and we're hearing a lot of input that maybe we should consider other factors. One that's been mentioned, for example, is life expectancy. If you're living in a city that's very expensive, you might be in an underserved area, but the cost of living is very high, and so you're not captured by our current measures. And so we're looking at what other factors we might incorporate that make sure that we're actually accurately capturing the challenges and the problems that we want to address. So like Mina and like Lee, we're all thinking about how is it that we can make a difference with the tools that we have in our toolbox to really address these disparities and inequities.
And in response to Mina's comment, when we looked at how well different groups could do by the percent dual eligible in the hospitals in our quality measures, what was critical was that except for those who have incredibly high dual eligible status, dual eligible percentages, that there were always groups who could achieve great outcomes, no matter whether they were in the top quintile the middle quintile, the fourth quintile. So that's really how we came up and how Mina and her group really thought a lot about this reward, because we know it takes extra resources. And you will have seen in some of our rules and in the SNF and other rules, some proposals around actually the additional rewards for high, good outcomes with a higher percentage, in this case, as you said, still trying to figure out the right measure, but dual eligibility status. Now, I'm going to give my colleagues warnings of where I'm going to go next, since they're not quite sure beforehand, but it's going to be about social determinant of health measures. But I just want to remind the audience, after this, we'd love to take your questions. We're happy to continue talking, but we think we're really here to help address some of the things you're questioning. So you may have seen, we're really incredibly proud in last year's rules, the idea of pushing out to many of the facility types, a request to ask, are there 5 questions around social determinants of health, the issues of food insecurity, the issues of domestic violence, transportation, and what is your percent positive? There were many groups who had concerns about presenting that, saying we take care of more patients who have vulnerabilities or these social determinants. We actually still felt it was very important. We have yet to come up with that final question of how do you connect them with those non-governmental organizations, within, and I'll be curious, within a model, people can be incented, but within traditional Medicare, it is more difficult to say, we're going to send you to a food bank and we can pay for it. But these are some of the things that we're trying to do, which is so important as part of the entire equity question of those social determinants. So love your thoughts.
Yeah, I'll take that. And social determinants of health is something that we're building into a lot of our models. So first of all, we ran a specific model called the Accountable Health Communities model that collected information. It required providers to screen for social determinants of health and then required them to connect their patients that in needs with community-based resources. And we found in both Medicare and Medicaid, it didn't meet the standard to be expanded under the statute, which we've decided is a pretty high bar and is almost impossible to meet. So we weren't able to expand it nationwide, but we're taking that tool, that screening tool, and we're incorporating it into a lot of the models. So that's one way that we're thinking about it. So now all of our models are requiring providers to collect social determinants of health data and do the screening. I think what we're finding though, unlike the Accountable Health Communities model, some of the providers are saying, well, if, we don't know where to go, we don't know where to send patients. And it's, I think, upsetting to them to find the high proportion of patients that have these needs and then not feel like they're able to meet those needs. So I think we're working on making sure those dots are connected. So that's one way. I think the other model I want to point out is the value-based insurance design under Medicare Advantage, and we're working closely with Mina on that. So in Medicare Advantage, when you offer a supplemental benefit, you've got to offer it to everybody. And what we're doing under the value-based insurance design is allowing those plans to target benefits. And so they can target nutrition, transportation, housing needs. We've added now needs that alleviate climate-related conditions, health conditions that are living in a hot area with lots of fires. They need air conditioning. They need other services that might be needed to be healthy when you're living in an area that's affected by climate change. And they can target those benefits. And we found that program is really growing. We're adding those flexibilities to some of our other models. And we're finding that there's a lot of interest in trying to find ways of covering the cost of addressing those needs. And so we just recently announced that we're expanding that model and continuing the value-based insurance design through 2030. And now we're going to require that 2 out of 3 of the social needs be addressed. So you can't just maybe address them, you must address them. And so in order to stay in the program, you've got to address those needs. So that's how we're thinking about it, and would love to hear from colleagues as well.
Yeah, I mean, I'll pick up on something that Lee said, that in traditional Medicare, you generally can't pay for, food at a food bank. In fact, we are rolling out a new program. So in our Medicare Shared Savings Program, we are taking a successful concept from a CMMI model, the ACO investment model, and we have created the Advanced Investment Payments Program, whereby providers, smaller providers from rural and underserved communities can apply to get dollars upfront that they can invest to address health-related social needs, so they can use this money to contract with community-based organizations to be able to serve their population, to invest in infrastructure, IT infrastructure, team-based approaches to care, social workers, et cetera. In doing so, they then join the Medicare Shared Savings Program and then become part of this overall model where they're then, ultimately held accountable for the quality of care they provide. And the goal is that they end up saving Medicare money and they share in those savings. And the test was successful because it was basically a really good investment. When you give money to these kinds of providers up front, they knock it out of the park in improving on quality and in keeping their populations healthy and out of the hospital and the ER. So we took that concept and are scaling it writ large in the Medicare program. And I think that's an example of where we're really trying fundamentally to change the way our programs work, where we are providing technical assistance alongside our colleagues in administrations for community living who run the area agencies on aging, alongside the Health Resources and Services Administration that has a lot of community workforce grants. So that way we can help connect the dots between people in the traditional healthcare sphere and the people who care for people's health. So, that's just one example of how we're really trying to embed equity into the very operations of our program. And on the Medicare Advantage side, we now require that special needs plans screen all of their enrollees for social needs. And that is also something that we are thinking about. How do we continue to move in this direction so that you are identifying social needs and then you are enabling the addressing of those needs?
And I think one of the key things is how much Medicare's CMS is listening. I mean, this is really from us going out there, seeing the innovations in the field, looking at the models, bringing them back. That is the administrator's key question to us. And that's one of her 6 pillars, is engaging stakeholders. So we'd love to see if anyone has any question to start right now.
National. Thank you all so much. I've met with all of you previously before, and I really just want to say, I believe CMS is listening. Having worked with CMS now over about 25 years and seeing just the trajectory of change of, going from just paying for medical care to now. So I really want to say thank you. With that in mind, though, I want to just we're part of the ACO REACH program. And I've had the opportunity of being a part of the TCPI program and working with clinicians as a clinician and seeing the transformation process. And so, whereas I'm very appreciative of these opportunities, what we're still seeing, particularly with our health plans, we work with health plans that have independent models, from MedStar. Well, MedStar has a staff model in as well. But for your clinicians that are serving the out in the community, what is some of the thinking around helping them in that journey? There's still, there's the Mayo doctor, right? That's got all the supports, but then you have still those community-based clinicians that are just struggling from the HEDIS measures. I heard you talk about, HEDIS measures. And there's just that challenge there. So just wanted to ask of any other thoughts and how do we kind of get those doctors, because they're really the ones that are out in the rural communities caring. Any other thoughts that you have that we can do to bring that voice of what's happening as the clinician? I heard the dollars that are out there, but many of them feel they cannot get to those dollars, right? because of a myriad of financial, especially with COVID having set many of them back. So, but thank you so much. So much is working and we've all got a job. So what can we do? How can we help you?
Now start. I think you hit the nail on the head. Like you can put out the most amazing policy and a regulation, and it really is, number one, about getting input to go into that regulation and then partnering to make sure that it actually comes to life on the ground. So we definitely need to partner with all of you. To give the example with the Advanced Investment Payments Program, we're talking with, public health departments, like this is something you're interested in. Let's bring together and have like a forum, a webinar to, talk through this with people so they know how they can apply. Working with organizations like help to forge some of these partnerships. I think it is really important that people, band together to make this happen. And again, this is also why we are doing a lot of these initiatives focused on rural and underserved areas. I mean, I'll give another example. We're rolling out 200 new graduate medical education slots a year over 5 years, so 1,000 slots. And we are prioritizing rural and underserved areas because, again, all of these programs are great, but if you don't have people on the ground, it's much harder to, enact. And if people train in the communities that need that care, they learn the needs of those communities and they're more likely to stay and practice. And so, again, really thinking about equity in absolutely everything that we do and knowing that we can't do it alone. So we absolutely need to hear all of your ideas and also engage with all of you to make sure that there is a provider who's interested in, being able to do more, that they don't feel that they have to figure it all out by themselves while they also have, a full panel of patients, right, that they're seeing every day.
Well, first, thank you for being part of ACO Reach. Really happy to hear that. And I think the Innovation Center has the advantage of working with those providers and organizations and facilities that want to be at the forefront of change. And so are really willing to push that envelope. And so maybe less pockets of resistance than the physicians that you're describing. But even so, I've visited and gone out in the community, and I'd love to do a site visit if you're up for it. You learn so much when you're on the ground and talking to people directly. But I've talked to ACO plans that say, our providers don't really want to screen people. They don't want to be asking questions. But then when they did, I talked to them again and they said, I had no idea the needs were so great among my patients and needs that really affect their outcomes and affect their health. So yes, there's that resistance, but also once they start doing it, and which they've got to now if they're in our models, they start finding that, wow, this is actually more significant than I thought. So we're hoping that this starts to catch on. I mean, look, electronic health records at one point was controversial too. I don't think anyone asked, we can all debate whether they worked as well as we wanted them to, but there was that resistance. And I think it's now accepted. So it's a trajectory. And I will say to the point about resources, and that's the model we just announced today, is really targeting those community-based organizations, the community health centers who haven't been in our models. They haven't heard about them. They haven't felt like they had the resources or the tools. They don't have investors backing them or the capital they feel like to invest. Those are the folks that we're targeting. This model was specifically designed for them. And maybe someday they can be part of Reach. Not everyone can be there, they may not be that advanced, but we've got to give them an on-ramp. And so that's specifically what we're trying to do with this model today.
I think with the on-ramp, piggybacking off of what Liz said, our work to align quality metrics across our programs is also an important piece of this, where if every provider who participates in the Medicare program has got to pay attention to some basic, health metrics, you develop the muscle memory that then you can say, hey, okay, maybe I can do one of these models because I have figured out how to work together with my colleagues and, deliver on these approaches to care. So being able to align our metrics is also an important piece of it so that you can help healthcare providers along the journey of value-based care and move into these models.
So I'll actually move off of both of your comments. One being, since Mina's sitting closest, that idea that, no, the Universal Foundation, the biggest criticism we have had is it's a lot of process measures, some outcomes. It doesn't have proms, but we want to clearly state it is the beginning. It is the start. We have the Innovation Center. We have a lot of other measures that will continue to evolve. The other thing in my role as CMO, I've spent a lot of time talking to the other octaves at HHS. And we recognize that there's a huge digital divide, and that's one piece. But even within the digital transformation of the health system, and Mina and I spent the morning talking about AI and the directionality. We're thinking a lot. We know in the ACO program that the ability to actually submit measures with all these different EHRs is truly a problem. So that we're working incredibly closely with the Office of the National Coordinator, with the CDC, with actually FDA, with our colleagues at NIH. There's something called the US CDI. It is the definitions that we hope all of the EHRs will eventually use, and we count on both CMS, our colleagues, as well as the ONC to get to that. There's something called USCDI Plus, which is developing the definitions for quality measures, but also for public health, because we have to prepare for the next pandemic. And the best way we can prepare is really having a digital data stream that is uniform, that each place doesn't have to have 5 people typing in the data, that we can use something called bulk FHIR, and we can pull it all in. So there really is an effort to look 5 to 10 years in advance. If Anish Chopra were here, he would say it would be done in 2 years. But really trying to get the EHRs to align around common definitions that make submission much less burdensome. In fact, the idea is we just pull it in from the cloud. Question in the back. Yeah.
I debated the fairness of asking you a question in public, but I'm doing it anyway. First, you all are doing great work. Where you are pushing agency policy is, I think, exactly right across all of your programs. I encourage you to keep pushing both in MA and Medicaid managed care. Everything that you do to push us on equity, to push us on social is valuable. My question is, I wonder if we're thinking about the connection between health and social backwards. So we still continue to want to use the healthcare infrastructure in order to connect members or patients to social needs. So you're putting, whether it's a health system or a physician's practice, at the center of a model, and intrinsically those are more expensive. Even though one is more expensive than the other, they're more expensive than social needs care delivery. Could you envision a model where you put social workers at the center? Because when you actually survey members, you find that there's a tremendous segment of membership, for example, for us in Medicaid, but other lines of business as well, where their primary need is actually social. And we try to fix it or address it through a physical care model, which just doesn't work for them. So imagine a model where you put the social worker or the community health worker at the center. That is whom CMS pays and or the health plan pays, and you commoditize the physical care delivery. In other words, the social worker can help the member get connected to physical care when they need that, but otherwise spend 90% of their resources on food, housing, transportation, domestic violence, et cetera. Would that be feasible?
Looking at that, and for example, in maternal health, thinking about the role of doulas and community health workers. So we are looking at what more we can do, but remember that, I mean, who was it that said they go where the money is? Why do you rob banks? I go where the money is. Like if you think about where all the money is in the system, it's in the healthcare system. So you're right. We might be looking at that wrong, but there's certainly more resources. That's where we've put them. Not necessarily saying that that's the right thing to do, but trying to look backwards. We're thinking about that in the way that we think about models. But that's a challenge to overcome.
A very good point. There's a few aspects to it. For the Medicare program, first and foremost, there are certain requirements in law on who we can pay, right? And our levers are primarily around payments to providers that are in the much more traditional way of thinking of healthcare providers. So some of what we're trying to do is expand where we can through that lever to then work around. So for example, to give the example of the advanced investment payment program that we were talking about, we could have just said, we're going to give this money to the primary care doctor and you need to figure out how you're going to address food, housing yourself. But instead, we are encouraging them to then use that money to contract with a community-based organization so that you have kind of some more flows of funds. And this is one of the things that we've been talking with ASTO about, you know, the National Organization for all of the state and territory public health organizations. Where are there ways that you can actually triangulate where money can come from between, you know, public health tends to be much more in that grant universe. And we work with kind of the healthcare providers on the like payment for a service universe. Those two should be connected. And so those are some of the ways that we're thinking about it. We are also exploring, particularly in our accountable care organizations, to be able to think more broadly around how someone can be part of these organizations, right? Traditionally, you had to see a, you know, primary care physician to become part of one of these models. And we're thinking about, what about nurse practitioners? What about a social worker? Are there other people who are involved in someone's care on a regular basis where it would make sense to say, okay, that becomes the hub, you know, for these models. So that's something we're exploring as well.
With regard to that third measure that we have yet to write of, did you screen? What's your percent positive? And did you complete the loop? We're still thinking through, and we've taken a lot of stakeholder input of what should the healthcare system really be responsible for. Is it a check the box? Is it not? We're concerned about that. So we're still looking for the right way as far as a quality measure of closing that loop. I saw a question.
Hi, I came from Puerto Rico. My name is Dr. Rodriguez. I came from one of the Medicare Advantage programs in the States we have is MCS. I was wondering, we're talking about community health worker, and I understand, you know, the payment situation, but what about the clinical social workers? There is a specific license requirement for them, and they're part of the triangle you were talking about.
Yeah, so actually in our payment regulations last year, we created payments for licensed clinical social workers, particularly to be able to provide support services and behavioral health care integrated with primary care visits. So this is an area that we are, you know, absolutely looking into. And it's very exciting in the latest budget omnibus law that passed. Congressional action is enabling us to potentially expand the list of billable providers to include licensed marriage and family therapists, licensed mental health counselors, you know, to be able to build an intensive outpatient program in Medicare, which has been a huge gap in behavioral health coverage in the Medicare program. So we are definitely exploring all of these avenues now, because I think exactly to the points that a lot of you are making, it is long past time for us to be thinking about health beyond that ICD-10 code and E&M code that the MD bills. So, you know, I think we are really working, you know, and also to community health, we did a request for information last year on how community health services could be paid in the Medicare program. And we got a lot of feedback on that. So we are absolutely thinking about all of these avenues so that we can actually address the health of someone, right? Rather than just treating them when they're sick.
Screening tests in the office, but it's not that we don't want to participate in the screening process. It's what do we do with the answer we receive
Yeah.
from those?
Yeah.
Thank you. I think I saw another question, which is probably our last.
So much. Thank you for taking this. I was wondering if you could explain a little bit about why with the new model, ACO participants are unable to participate concurrently.
Yeah, you know, we gave it some thought and we think that it doesn't make sense to be taking the incentive payments over here and also the shared savings over there. And it sort of is maybe, it's not double paying, but I think we had concerns about mixing the incentives. I know the ACO community wanted to be able to be concurrent, but that's not how the model was designed. And what we've told them is, look, we're going after providers who are new to value-based care. About half of providers, primary care providers today don't take any value-based care payments at all. And 3/4 of them are not in an ACO or our current primary care model, primary care first. So we want to provide that on-ramp. And I think from the ACO's perspective, someday they may be eligible and ready to join an ACO, but not all providers want to join an ACO at this point, and we want to provide enough pathways to be able to get there. So
Well, actually, I think we've got about 7 minutes left, so I wondered if you had any final comments from my colleagues.
I think, you know, someone made the comment that CMS is listening and we're really using the levers that we have to try to make change. And I think that's how I see my job, is really what tools do we have and what ability do we have to make a difference? And we have certain directives, and one of them is really to embrace health equity and advance health equity and really address the disparities that have been part of our healthcare system for decades and decades and decades. And what is it that we can do in our time here to make a difference? And I think we've all taken that challenge and welcome any feedback or input. So anything else anyone thinks we should be doing, we're open to hearing more.
And I completely agree. I will also say these are amazing people to be able to be on this journey with and work with. You know, another theme that we've been talking about is that we really think about equity in everything that we do, and I cannot emphasize that enough. So I'll give another example. I think this is like one of the first speaking engagements where I haven't been asked a question about the new drug law that we're implementing. So might as well continue that streak. So Inflation Reduction Act, right? It is not sitting there somewhere in a silo where we are making changes to prescription drug coverage. We're setting up a negotiation program for Medicare to negotiate drug prices with pharmaceutical companies. It is part and parcel of our equity agenda, where now people can get vaccines without paying anything out of their pocket. People don't have to pay more than $35 a month for insulin. And we all know the statistics on diabetes and underserved populations. And I personally took care of patients who could not afford their insulin. And as we think forward and we think about negotiating drugs and we think about what is the benefit that a drug can bring to populations, being able to really bring to the forefront, does this drug address an unmet need? How does this drug impact and address the specific needs of specific populations? We are putting equity into absolutely everything that we're doing. And it's really important for all of you to challenge us, to find the opportunities in all of our programs where, hey, here's a place where you can address a disparity that exists, because we really want to have equity be the underlying current of absolutely everything that we do.
So people have asked what surprised me the most, because I was in academia and practice for 30 years before I came in. And I think what surprised me the most is how much we actually listen to how people respond to our rules. We ask questions. And when my team briefs me for any decisions, I actually ask the question of who made that comment? You know, who is saying this is too burdensome? Is it the patient advocacy groups, or is it the industry we're regulating? And it really has influenced everything we do. So I'll go in the other place that people always ask the question when I'm around, which is the Alzheimer's drug. So you may have seen that when the administrator put out the final decision, that it included issues of, did the clinical trials have enough representatives of those in whom have the disease, and how would that affect treatment? So it is embedded in everything we do. just want to thank my colleagues for tolerating the fact that we did not have a prep. As well as the opportunity to share the podium today with them and your questions. Thank you very much.